So it's my next pleasure to introduce to you Dr. Anthony Bafo-Bani. He is the Medical Director of Infection Prevention and Control at the Carilion Clinic Infectious Disease in Roanoke. Are you in Roanoke or New River? Roanoke, okay, all right. I read that on the internet, but then y'all said y'all were from New River, so I was, all right, so. He's also an Associate Professor and Section Chief of Infectious Diseases at the Virginia Tech Carilion School of Medicine, which I am so excited that Virginia Tech has a School of Medicine. Back when I went to Tech, we didn't have that, so I had to get my nursing from somewhere else. He got his education, his medical degree at the University of Ghana, and did his internship and residency there as well. And then he came to us for his fellowship at the Virginia Tech Carilion School of Medicine. And for this year, he has been named as a top doc in infectious disease by the Virginia Business Magazine. So it's my great pleasure to introduce you to Dr. Anthony Bafo-Bani, who will talk to you about Mpox vaccination.
So thank you again for the kind introduction. To actually answer one of the questions asked about why we may be even seeing a higher incidence of Mpox and severity in African American population or Latino population. I don't have the slides here. However, when we look at the individuals who've had access to vaccination, the care for access, you see that Caucasian or white population has the highest access. So people who are susceptible or have likelihood of getting Mpox, the highest access is white, and then you have Latina and Black as the lower access in terms of very little access. And so working in communities to make sure that when African Americans or Latina feel or trust and go to get their care, it's actually going to be very important with Mpox care. And that's vaccination. Essentially, you can have all the vaccines in the world. If people don't trust, they won't show up. If they don't trust in the efficacy, or they don't trust in the science, or they don't trust in what to tell them to get it, they're not going to show up. And we all know what we're talking about. So, no one's disclosures. I will be providing a brief update. Some of what I'll be saying has already been discussed. The reason I'm sort of bringing it up again is it's extremely relevant as we understand we should be targeting for vaccination to make strategies successful. I will be, as I said, identifying strategies to increase vaccination and discuss how to incorporate Mpox vaccination into routine HIV, STI care. So this has been shared in the US. We saw this big spike, and then with vaccination, natural immunity, behavior change, we saw a decrease after somewhere around August. We started seeing a gradual decline. But what is relevant in this story is that it's not a decline to zero. There is still something happening, subterranean. We're seeing cases. It's not a decline to zero. And intermittently, there are cases here and there. In Virginia, again, this is information that has been shared. It's the same thing. There is a decline, but it is not a decline to zero. And so there is that likelihood that we can see upsurge cases from time to time. The age group, again, this has been discussed, but it's important as we develop our messaging for we target in terms of messaging. The majority MSN, male and younger age group, 20 to 49, I call it younger now, and 91% are in that age group. And again, you can't see the race distribution as was talked about. So what are some of the prevention and control strategies that the WHO suggests? Quite a few of them. One is maintaining that surveillance, making it a nationally notifiable condition. So across the world, this is something that different countries are doing, including Virginia. Integrating HIV care and STI, monkeypox care into HIV care, essentially trying to normalize the disease in a sense that you can capture individuals locally. That's another area. But what I'll be talking about is enhancing access to vaccines. I won't be talking about therapeutics. It will be done at a later time. So again, in the US, you can see this is an MWR paper that showed that quickly the US came up with a case definition and identification. They very quickly engaged providers and the community on how to identify cases. That really helped. And then, very quickly thereafter, there was the Genius vaccine access to that. It wasn't as initially a very robust access, but as mentioned, there were strategies to on how to vaccinate to have more vaccines, even for the same vial. And so that increased access. Some testing and treatment came online, more vaccine access. And then what is important again is addressing the disparities related to access to treatment and vaccines. I will be talking mainly about the vaccine aspect of what we're doing. So I think this has been shared in different ways. This is Chicago. Everybody thought we're out of the woods. We all thought we're out of the woods with monkeypox, and then boom, they see a big outbreak or resurgence. And then the same with California. They also saw a resurgence and quickly identified it. One was May, another was October of 2023. This is after we thought we had come out of the woods. That could easily happen here, as has been described earlier, that we may be seeing a slight uptick in cases. And so we do have to work hard to make sure that our providers have an understanding of what the disease looks like and then how they can prevent the disease in our communities. Messaging really matters. One of the ways to prevent outbreaks or to control them is messaging. And messaging has to be culturally sensitive. So we talk race, but there's also socio-economic status, individuals who may use drugs, you want to make sure that the messaging is right for different populations. That messaging should be clear about what is known about the disease, what scenarios lead to increased risk of spread. Just being MSM doesn't make you more at risk for Mpox than being heterosexual. So important to stress in very simple ways the science around why there is increased risk of spread. Sharing, like has been shared today, data on most affected so that can influence policy as well as messaging is also very important. And then sharing actions that have been proven to stop outbreaks is also very important. So getting information from other areas. It's important to engage and listen to communities that have been affected. Without listening, without knowing what communities see as the best way to address an issue, we just come with our own solutions and think we're doing something. Normally, it doesn't work that way. And then leveraging trusted sources of information is another important way. So not just the message, the content of the message is important, but who delivers it, how it's delivered is also very important in these issues. That's the second. So going to how messaging be utilized, this is a study published MMWR that looked at what messaging did after what messaging did for a group of gay, bisexual, other men who have sex with men to prevent Mpox. At that time, it was called monkeypox. This is before the name change. So they asked individuals, okay, after messaging, did you increase the number of sex partners you had or not? And so they used the signs to message, and there was a significant decrease in the number of sex partners. It wasn't very high decrease, but there was a significant decrease. What about multiple sexual encounters? They also saw a decrease. What about having sex? That also saw a decrease. What about the use of condoms? Actually, the was no change. They didn't see an increase. They did not see a huge increase in the use of condoms. In other words, get the message. They are able to, and the right message, they are able to actually make changes in their practices, and behavior change does improve on control of infection. What about strategies to increase vaccination in eligible persons? I'll call that vaccination 2.0. I'll talk a little bit about Genius and then come back to the strategies in a week. So there are two vaccines for preventing smallpox and Mpox. One is the Genius, and then the other is the ACAM 2000. So the ACAM has a replication-competent live Yersinia virus. And when, for some people, especially if you are immunocompromised, you can actually develop some pox lesions. It's not used in the US at present for this outbreak. It's the Genius virus, which is replication deficient live attenuated virus, which is used. And it's used, that is what is used in the current outbreak, mainly for FDA for persons over 18. But there's an EUA for individuals under the age of 18. This is sort of a comparison between the ACAM and the Genius. It's important to note that there are less adverse side effects or adverse events related to the Genius, very minimal. In fact, in terms of cardiac side effects that have been described before, the is significantly low compared to the ACAM. And then the Genius can be given both intradermally as well as subcutaneous, and usually 2 doses, 28 days apart. So initially in February 2023, the ACIP's recommendation was we use this Genius vaccine during an Mpox outbreak. So that was sort of the general thing. We have an outbreak like this, we show the curve, that's when you use this Genius vaccine. But having now understood that this disease seems likely being persistent in the low levels, the advice since October 2023 is that use it for persons at risk. So don't wait for an outbreak, use it for persons at risk. So then the question is, how do you identify persons at risk in a manner which is not you don't want to stigmatize them and then direct them to get it. That's really the crux of the matter, is identifying who's at risk and then doing it in a way, adding it into one's workflow that we already have. We have lots of different workflows for STI. How do we sort of bring that into the mix? If the risk exists, essentially discuss and offer the vaccine. Okay. So what is the Genius eligibility? And some of these slides I put from the VDH. I love them. I didn't have to read them with you. suspected exposure to someone with Mpox. That makes a lot of sense, and normally we would do it within 4 to, as early as possible by day 4, but even up to day 14, it can mitigate the severity of disease. Known or suspected exposure to somebody with Mpox. That's an indication for the vaccine. If one has had sex partner in the last 2 weeks that was diagnosed with Mpox, that's the same thing as I just said. If an individual is gay, bisexual, or someone who has sex with men, or transgender, non-binary, gender diverse, in the past 6 months, has also had a diagnosis of an STD, chlamydia, or one sex partner, suggests that this, individual would be eligible for it. So it's not just being gay or bisexual or transgender per se that makes it relevant. The issue is that intimate contact with multiple sexual individuals, or with somebody. When you get an STD, you know that these viruses and organisms tend to travel in pairs. So that would be the time to offer it. Or one has had info in the past 6 months, so you don't have to be MSM, the transgender. Sex at a commercial sex venue, like a sex club or bathhouse. Sex, now people ask why these, because I think actually, there's a lot of epi data that shows how some of the outbreaks have occurred as a result of that. The 2022 outbreak actually started in, I think, either Portugal or Spain, where there was this nice, festival, and there was a lot of, sex going on. And then 2 weeks after, in the UK, Spain, they started seeing cases in their STI clinics. And initially, I think it was syphilis, was it HSV, and the UK guys initially, I think it's UK that diagnosed it first. The other STI clinics sort of caught on to the fact that this was something that was Mpox. But 2 weeks later, 2 or 3 weeks later, in Mass General, provider is seeing a patient who had gone to one of the sex parties in Europe. And so, just like a bit of most of these infections, they don't know his borders. They need a visa, they just come in. He was seeing a patient, but anyhow, picking proctitis, trying to figure out what was going on. The provider was at a loss, had tested for all the STIs with all negative, and sitting in her room, reading the journal, so this is happening to you, something like this is happening. So she immediately calls, other people, and then they quickly test for Mpox, and they identify it. So the data about the venues where the individuals can get it, these are simple questions that we can actually incorporate into some of our clinic related questionnaires or surveys to help direct individuals to resources that would be available. There are other eligibility criteria as noted by the VDH. So I'm going to go back to Genius and how it's, there are 2 ways of doing it. You can do the intradermal or the subcutaneous. I think the subcutaneous is the traditional way, just like how we give most of our vaccines. Goes deep down to the subcutaneous layer, and very effective. And then, but normally you need about 0.5 mils to prepare dose for that. With intradermal, it's almost like you do the PPD test for those who've done the PPD. Sort of, you get some people get that wheel, usually on their forearm, but can also be done in the back of the, it's a sort of sub in the back as well. It can be done in the back or even in the deltoid area. And there are pictures and things that the VDH has on their site to show how it can be done. Again, that can be done. We normally do one dose, and then after 28 days, your second dose, and after 40 days, you consider oneself fully vaccinated. So it's important for the provider to, and this is from the CDC, and the VDH has this on their site as well. It's important, though, for the provider to ask the patient. Some patients don't mind subcutaneous. Some patients will prefer the intradermal. It's important to let the patient know, maybe with the intradermal, if you are at risk of developing keloids, you probably don't want to be doing it in an area that is obvious and can be seen. So it's important to let the patient know the pros and cons of either area. Okay. So with vaccine administration, people with suspected or confirmed Mpox, if you think they have the lesions, that's not the time to give the vaccine. If you think they actively are having an issue, it's not the time to give them vaccine. As I said earlier, subcutaneous and intradermal dosing regimens are interchangeable. And again, the goal is to make the patient feel heard. If, let's say, they came in the first time, you did a subcutaneous, and the next time they say, now I want intradermal, the key is get the two vaccines, and they may have a reason why they want one versus the other. So that's very important to do. Some patients will have concerns with the intradermal administration due to potential stigma. They may say that, it may leave a mark and everybody may think that I have something. Those things are very, very nuanced, but we have to have that empathy and listen to our patients. I'll say this, so I treat a lot of HIV patients, and some of my patients will say, I want the intramuscular shot. Recently that we have in the intramuscular shots, I wanted, and I'm like, why do you want to change it? They'll tell me, I don't want anybody knowing my business. And so I just want to get my stuff here and be out. And there's one particular patient who made me understand that. So this guy, his viral load is always up and down. But when he takes his medicines, it's down. But the thing is, he stays with family, and he doesn't want his family to know he has MSM. And so it's not even the HIV, the HIV. He doesn't want the family to know he has MSM. And so he hides his pills. So he gets his pills, he fills them every time, but he hides them. Because if somebody were to find out, why are you taking these pills? Then he wants to say, okay, the next thing is, how did you get HIV and that stuff? So that led to his being non-compliant. So the moment we talk about the use of intramuscular, he can get it in the office. He quickly went for it. And so it's important to listen to our patients when they say, okay, I want intradermal. Yeah. I think the preferred, because it allows us to have more vaccine, would be the intradermal. However, not everybody may necessarily want it, and it's something to be aware about. Okay. The intradermal and the subcutaneous work very well. I think that has been said earlier on 86% efficacy in even the full 2 doses. So they work very well in preventing disease, and they work very well in also preventing severe disease if one were to become infected. However, and we need to be honest with our patients, because it takes just one bad experienced by one patient to spread message around. We need to be honest with the patients that there have been cases of breakthrough, either with eye infection or with Mpox vaccination. Nothing in the world is 100%, nothing in medicine is 100%, and we need to let our patients be aware of that as well. But we also need to let them be aware that of the cases reported, they were all milder cases in terms of severity of disease. So there is the importance of the vaccine. The incidence of monkeypox amongst unvaccinated persons compared to persons receiving the gene vaccine. This is an important data that we need to share with our patients. Remarkably different. So monkeypox, the vaccine, the Mpox vaccine, the Genius vaccine, remarkably decreases the risk of Mpox as shown in this diagram. And this is messaging that we want to be pushing as we see our patients. However, key questions remain. The effectiveness in people with immune conditions like very poor control HIV, CD4, and 100 or 50, or other medications that are significantly immunocompromised. And I think there are some key questions that remain there. There's still the question about duration or durability of protection. I think that will be answered in the coming years. But it's important to be open and transparent about that when our patients ask us these questions, so that when there's a change in knowledge, then we are able to reshare it back with the patients, and then they are more accepting and trusting of the provider. So despite the significant vaccination that has been done in the US, and most of it, as you can see, was, this is 2020, is around June through to about December of 2022. Most of the vaccination happened, and then there was it's now sort of tailed down with a small spike somewhere around June of 2024. I think this is where the Chicago cases came back, and then we sort of had more vaccination kind of out of sight, out of mind. It's talking about it, nobody's getting the vaccine, and therefore that's why making it part of our routine care the important thing. The VDH in Virginia, not VDH, in Virginia, we have, I'll just focus on Southwest Virginia. I think we have the lowest rate of vaccination in Virginia. Southwest Virginia has, this is data from 2/6/2024, 524 sort of administrations. So we have the potential to do even better. So I was thinking about, I don't have maybe in a clinic, in any clinic, it doesn't have to be an infectious disease doctor's clinic, because guess what? People, when they get a rash or they have STI symptoms, they don't go to an infectious disease doctor. They go to either the urgent care, they go to their PCP, or ED sometimes. Not a good use for the ED, but it happens. Depends on the severity though. But what if facilities, the doctor's office had, just like you have these magazines that, you can get a car, you can get this, call this number, you can get, what is my Mpox risk, or what is my risk? And if somebody in the waiting room, they can just do it on their own. And with something like this, if you say if you have any of the above, or you say yes to any of the above, maybe there's a QR code. You can call this number, or you can reach to a provider or something like that. We need to bring this into our primary care settings, because it's not every patient who tell the provider they trust their sexual habits. However, if they are reading this by themselves and then making this call, that's all we need is the shots in their arms. Doesn't matter who gives it. We just need a lot of shots in their arms. So this, I'm sure, there will be things like that in our systems very soon. But I think this would be one thing that we want to adopt. The CDC, and this is highly leveraged by the VDH, has the Mpox vaccine locator. But before you get to this, you need to have somebody, you need to have a way to get to this. People don't just go Googling and saying Mpox locator. Because they need to know about even Mpox. They need to just know that there is that condition, and that condition may be associated with more than one partner, STIs, and so when they know that and they have this on top of it, that makes the Mpox locator and this type of work very well. What about expanding access through community partners? And I think you mentioned something like that about community-based organizations, or vaccination by non-local health department providers. So as of October 2022, non-LHD trusted providers can order and administer genius. And I think this is genius that we are doing this. The vaccine is genius, but it's also genius that we are doing this. It's very, very important because most patients receive their care typically with their PCP. So getting as many individuals, even outside of the local health department, who will do this, or if the individuals are able to point, non-LHD providers are able to point quickly to the local health department, that becomes extremely important. The VDH has resources for that, and I think it's an excellent resource that should be utilized. And there's science behind this, actually the San Francisco city story. So we say, San Francisco or California, they noticed that the highest incidence of Mpox in their population was in the Latina African American population, and they were vaccinating up the wazoo. They were just vaccinating here and there. You can see the San Francisco Department of Health mass vaccination clinic, 18,000 vaccines. That's a lot. Kaiser, 8,000 vaccines. UPSF, 3,000. Everybody was vaccinating up the wazoo. Let's see, SFDPH Sexual Health Clinic. They vaccinated 1,488. But the thing is this, the San Francisco City Clinic, vaccinated, they didn't have a large population. You can see that amongst Hispanic, and actually in this case, Hispanic, they did the highest percentage of Hispanic vaccinations. The essence of the story is, depending on the population, one may have, let's say, you may have Caucasians maybe whites go typically to the local health department because they have trust there. They go there. You may find that the African American community in your area may have a place they trust to get their care. So what we do is we need to bring those vaccines there so that when they go there, they can get their vaccines. And so if, let's say, we did all the vaccinations at the San Francisco mass vaccination clinic, it's possible that the mass vaccination clinic is held in an area. You have to take a bus, or you have to take a car or get there. And the individuals you want to vaccinate don't even have the ability to get there, or cannot take off work to go there on the day doing the vaccination. So the ability to get our vaccines in multiple areas that are also culturally sensitive becomes extremely important, as evidenced by the San Francisco City Clinic Store. So that's a success. Now, should Mpox be integrated into HIV and sexual health care using a syndemic approach? And I think somebody shared this already. Mpox, it's vice versa. We need to prioritize people with HIV and STIs for Mpox vaccination and the other way around, offer HIV and STI screening for individuals who are evaluated for Mpox, given the high incidence of co-infection that has been identified. So not only do we want to make this a practice in terms of, you have your clinic patient, they are not coming for STI care, but you are asking them through surveys or through maybe a little questionnaire in the waiting room or when they are in the examining room. Before you see them, you are asking them so they can actually make decisions. So one can bring it into your practice. A lot of primary care, you've got to see patients quickly, boom, boom, boom. So you may not have the time to go through all, but at least while they're waiting, if they can answer and get that care, that's good. And then when patients come actually for STI, that's another opportunity then to also introduce Mpox vaccination for them. So persons who require treatment for STIs, example, chlamydia, gonorrhea, as I said, should be evaluated for Mpox, and then vice versa. And then whilst doing that, where appropriate, the vaccinations for HPV, hepatitis A, and hepatitis B, because it's still there. Those infections too are still there. They can cause outbreaks quite a bit. Vaccine hesitancy, and is there vaccine hesitancy? So even before the pandemic, the popular COVID pandemic, vaccine hesitancy was one of the WHO top 10 problems. And they had identified it in 2019 amongst things like air pollution, climate change, Ebola, and other high threat pathogens like Mpox. So vaccine hesitancy was something that had been identified. And there are many reasons for vaccine hesitancy, that the various shades of vaccine hesitancy. I want to talk about a study my group and I did with regards to healthcare workers and vaccine hesitancy. This was related to COVID-19 vaccine. And what we identified was after review of the literature and doing a survey of about 2,000 to 3,000 healthcare workers, we noticed that individuals trusted their personal providers to give them information about vaccines. Now, this is very heartwarming. So the next day I go to after we got this data, I go to my clinic and I tell my patient who has HIV, hey, you got to get the COVID vaccine. It's like, hell no, I'm not getting anything. But the data shows you trust. Well, okay. 3 months later, it comes in for follow-up and I ask him, so have you gotten your COVID vaccine? It's like, oh yeah, I got it. I'm like, why did you get it? And say, oh, you told me to get it. So just mention it. They trust you. And they can do it immediately. But these things ruminate. And then after a while, they do it. The patients trust their providers. And it's important that we educate providers about Mpox. So when they educate their patients who are eligible, we know they're going to do it. And it's actually the same way I put in a plug for another study we did in the community for antimicrobial stewardship. Comes back to the same thing. Patients trust their providers, even when it comes to, you will see a doctor and say, I've got a sinus, and normally if I don't get an antibiotic, I get a pneumonia in 2 days, 3 days. And, usually you got to write an antibiotic. It's not good for antimicrobial stewardship. So we wanted to find out, because we're doing some messaging to our providers, and our providers said, wait, usually the stress comes from also the patient. Are you looking at that? And what we found was when patients are given the right information about antibiotics, they actually trust their providers in terms of following their advice. We don't realize that. So our providers hold the key to us moving the needle when it comes to many things, including stewardship, as well as including vaccine related stuff. So just wanted to mention that here you have a big voice here, but not all patients have providers. So that will capture some. Some patients you still have to work with local, community-based organizations where people get their care, where people do their talking, and to make sure that we are giving the help there. This is another study. It's a lot of words here, but it's another study that looked at vaccine hesitancy for Mpox. It's a qualitative study. The key things to note is that for those who did not receive the vaccine access, they stated that access to the vaccine, easy access, and availability were the main barriers. And access can be the distance to drive or the time that the office is open to get a vaccine. Some people cannot take off work for it. So we have to have different ways in which we are doing or giving vaccine. So lack of accessibility and then also the stigma associated with receiving the vaccine was another thing that was associated. And so that's why if, let's say, a provider says, the patient says, I don't want to get it intradermal in an area, when we suggest the different other areas that they can get it to reduce that. That's very, very important. We need to hear our patients. So tailoring outreach and education campaigns to address reasons for Mpox hesitancy becomes very important. So what are the takeaway points? What can providers do? The cases of Mpox has decreased. That's very true, but we still have sort of a smoldering and infection going on. There's always the risk, especially in the summer months, as there are more parties, raves, and different things to get outbreaks. It's important that there's a lot of material the VDH and the CDC have integrating some of these into our practices, including having simple questionnaire in the clinic may be helpful. That continued messaging and that messenger that Genius is safe, effective, and the best way to protect people at risk is also important as well. And then staying connected, making sure we are doing, I think somebody already did, CDC, POCA updates, the hand calls, VDH programs becomes also very, very important. Thank you.